it's wise to take the Provigil or modafinil or armodafinil on the road so you don't run into accidents. Somebody might have, a meeting where they have to sit for a long period of time. They want to get alert and awake. So these are medications that we say, use it. It's more symptomatic treatment. Some cases you can use it daily. People use it on as needed basis. The management of sleep apnea is always like a chronic medical condition model. There should be follow-up into the case because apnea, changes as we change in weight. It changes when we develop other comorbidities. Somebody might have had a TIA or a stroke, or heart rhythm or heart function might have changed. So the management could change from a CPAP to BiPAP or to other levels, or it could be de-escalation of treatment. Somebody might have done the efforts, have lost significant weight. The CPAP pressure might be high. We will revisit. And in that case, we might downgrade them to an appliance, or they might completely be off treatment if the airway is fine. So it needs a constant, dialogue and constant interaction. I would stop here and I would open for, questions, and then we can elaborate.
Sure. There's a question here. You had talked about, I think, just clear this up. So you had talked about how, when you fall asleep, you have these episodes. And so a patient asked, how do you determine whether a fainting spell is related to apnea or syncope?
So that very important question. So apnea can produce what we call dysautonomia, the autonomic nervous system, the sympathetic parasympathetic nervous system, can get affected with airway obstructive disease, mainly the one that we call, I didn't touch on it, upper airway resistance syndrome, where the airway resistance is high. There is a swing in the chest pressure. It can bring to what we call a cold hand, cold feet kind of symptom, but also fainting type of episodes. There's even a condition called POTS syndrome. There's posterior orthostatic hypotension. Basically, someone stands up, they feel dizzy, they feel lightheaded, and they have upper airway obstruction, and we treat with CPAP, they actually improve a lot. So the main thing is to go through the history in detail, because syncope could be from different reasons too. And is it orthostatic hypotension from different reason? Is it volume issue? Is someone dehydrated? Is it cardiac rhythm issue? Is it a carotid artery issue? Is it an aortic stenosis issue? So we have to go through the list. But again, an apnea would be one of the considerations. Mainly upper airway resistance syndrome is the one that's associated with this. So detailed history, look at the other cardiovascular evidences, and then do testing. I'm not hearing you.
Sorry, next question. I get this a lot in primary care where patients go, they see a sleep doctor, they get diagnosed with sleep apnea, they're given a CPAP, and they don't tolerate it. So a patient here said, I tried the CPAP, I could not adjust the mask and hearing airflow, even after adjustments, so stopped using it. Never realized how sleep apnea may relate to my high blood pressure, depression, weight increase, and frequent urination at night. So what do you offer? I know you talked about some other
alternatives. Yes.
Maybe more specifically, if somebody doesn't tolerate a CPAP, how do you?
Good. So the first thing is, before saying CPAP intolerance, the most common reason why people fail CPAP is they have upper airway obstruction, nasal obstruction that has not been addressed. So the first thing to look is there nasal septal deviation? Is there enlargement of the turbinates, the inside structure of the nose? Are they mouth breather? Are we using a nasal mask on someone who has nasal obstruction? In this case, it's very difficult to tolerate CPAP. So the first thing is to look into, why is the CPAP failure? Is this improving the nasal passage that's when it needed, or do we need changing the mask? Is this a pressure issue? Now, having done all of that, not everybody tolerates CPAP. And if they don't, if there's no significant nasal obstruction, is when we will go buy a mouthpiece or an appliance. The reason why I stress on the nose is to use an appliance, we should have a patent nasal passage. Again, the first thing could be having the ENT evaluate and correct the nasal passage before going to the mouthpiece. If this too doesn't work, is when we go to Inspire, but Inspire needs a thorough evaluation. Because some of the conditions, if someone has irregular heart rhythm, do you use Inspire? These are unanswered questions. But if the patient fits that strict diagnostic criteria, then that's where we will go next.
And then I maybe just talk a little bit. I have patients who you see and they get fitted for like the pillow mask, just a little bit of a different attachment. Can you just explain that a little more?
Yeah, so the type of masks are, one is nasal. The nasal, there's a small nasal cannula that we use for oxygen. Now, the next level is slightly bigger. We call it nasal pillows. These are slightly thicker, but they fit into both nostrils. They're connected to the plastic either that comes from our head or they come on the side. If the nasal pillows don't work, there's now a mask that sits outside of the nose without even going in. These are the dreamwear mask types. So they all assume you have a good nasal passage. The pressure need usually is lower when we use nasal masks. Good for people who have claustrophobia at the same time. But if someone's apnea is very high, we're going to use high pressure. Then we use a full face mask, which covers the nose and the mouth. And there are many different types of full face masks as well. So the scenarios depend on degree, presence of nasal obstruction, if someone has claustrophobia or not. The most important piece in apnea management is getting the right mask seal. So that could take sometimes, trying different levels.
Okay. All right. We have a few questions here, so this is exciting. How likely is it that you will get off a CPAP machine if you lose weight?
Actually, very important question. So when I put someone in a CPAP, unless they have bony structural issue, craniofacial, like a normal weight person who has overbite, the weight is not going to be the main factor. But otherwise, I always say, let's work with the CPAP plus weight reduction. So our goal should be to get rid of the CPAP. We have had tremendous success in many patients. Of course, the success is much higher in more aggressive type of weight reduction, the bariatric surgery population. More than 50% graduate from a CPAP, as long as they maintain the weight loss. But 10% weight reduction in apnea gives you a 25% reduction in the apnea severity. Which means if your apnea number was 10 an hour, then you will reduce it to 7 an hour or 6 an hour. That's significant gain. So you could then rely on mouthpiece or side position. You may not need the CPAP. So weight loss gives you the most gain when it comes to sleep apnea. Is the chance of getting rid of the CPAP is quite significant if there's no bony structure issue. What I mean by that is, like, if you see apnea all over the world, the highest is in Singapore. The next one is China. So Singaporeans and Chinese, they're not, overweight people, but nasal passage, bony structure, bite, high arch palate, these are structural things. So those would not go away with weight reduction. We've learned the tongue itself, when we increase in weight, the tongue itself accumulates fat. In fact, MRI studies of the tongue shows the fat content goes down when we lose weight. And there are procedures that I didn't touch about. Tongue-based reduction by radio frequency could be done as an adjunct. So if someone loses weight, there's mild apnea, there might be a need to do radio frequency reduction and no need for CPAP. So weight loss is big too.
Yeah, and here's a follow-up question to that. It's specific to the patient, but the patient says, I was diagnosed with sleep apnea several years ago, maybe about 5. I've recently lost over 30 pounds, about 18% of, I'm assuming, body weight. And I wonder if I no longer have sleep apnea and no longer need to use a CPAP. How would I be able to find this out, and would insurance cover testing for this situation?
Yes, this is what we mean by significant weight change when it comes to sleep apnea.
Okay, so would this be a good virtual visit to do with you now, and then you can arrange for a sleep study? Would that be the best way for that patient to proceed?
Yeah, so if they make a virtual visit, we'll do the connection, because insurance always likes to see our note and the justification for testing. Then we'll proceed. Office will do the authorization and we'll contact.
Okay. And then here's another more specific question. Thank you very much for the great presentation. Here is my question. Based on 2 home sleep studies with your clinic, the diagnosis of sleep apnea was confirmed. I'd like to try the device, but was scheduled to the in-clinic study. Why do I need the additional in-clinic study? And can I try the different devices now?
So no, we can go 2 different ways. In ideal setting, there are scenarios where we say someone has to be in-house. The reason is the in-house monitoring detects more other things, particularly what we call periodic limb movement if we see a lot of fragmentation of sleep. If there is any question for heart rhythm issues, we would like to do an in-house monitoring, because these are things that we will not get by a home intervention. But given the scenario now, given the COVID issue, because we're holding off from in-house, if you have the diagnosis already made, I think we can start prescribing the CPAP, the adjustable CPAP, with monitoring of data from a distance. So if you could just send us on a portal message, we should be able to arrange that.
Okay. Here's an interesting question. I recently fell asleep while driving. What follow-up should I pursue?
Yes. So that's the worst nightmare for me, is because to be honest, I need to share this with you. I myself have fallen asleep driving when I was a resident on I-55 in Chicago. And you can imagine, that's from a chronic sleep deprivation post-call. 1/3 of all medical residents had near misses or accidents. So it's a, very devastating type of thing. I have had patients who have been admitted to intensive care unit because of falling asleep behind the wheel from untreated sleep apnea. So anytime you have this symptom on a red light, you're dozing off or you don't remember what has happened, you have to take off a break and take a nap, on rest areas. These are times for you to make an appointment, get tested, because you will notice tremendous difference in daytime alertness, and you prevent, for yourself and for society as well.
And then maybe could you just mention some of the other the differential of falling asleep while driving, because not everything falling asleep while driving is sleep apnea or fatigue.
Absolutely. So the most common reason actually is chronic sleep deprivation. Like I said, the scenario with me was not sleeping as a resident, 36 hours at that time, now it has been reduced. So most common reason is it falling asleep? Is it sleep attack? Is it narcolepsy? Is it sleep deprivation? Or could it be something else? Was this a seizure? Was this a transient ischemic event? So these are things that we have to look. So that's when we'll go into details and we'll see, we need an EEG. Was that a seizure attack? Was that a vascular event? But more commonly, falling behind the wheel is sleep deprivation because of not getting enough sleep, because of lifestyle issues or shift workers or untreated apnea. And I've had narcoleptics do that too. So sleep is way up. And of course, seizure and other things, you will get other clues. Is it carotid? Is it sick sinus syndrome? So we go through the list to make sure it's not other events.
Okay, and then here are 2 questions that are sort of related. And then to our audience, we have time for questions, so please submit them. So here are the two questions. So one is, how often should you get a sleep study reevaluation done? And then how often should you follow up with your sleep doctor?
Yeah, so the retesting is done for a reason. A is after you have been stable, is there change? The current CPAP pressure is not giving me a good result that I want. Then that's time to look. My weight has changed more than 10 pounds either way, gain or down, and there is change in symptom. Then we do the testing. Or you have done the effort to lose weight and you want to make sure how things are. Or development of vascular event. Vascular event, what I mean is if someone has TIA, stroke, or heart failure, a stent has been placed, then I'd like to revisit because the apnea could change from obstructive to central to mixed apnea. And insurance usually covers 2 sleep testings for anybody, but we do it only if the reason is there.
All right, well, I don't see any other questions. Maybe I'll give people another 30 seconds if they want to submit any last minute burning questions. Dr. Mekonnen, do you have any parting words of wisdom for patients with regards to sleep apnea or sleep medicine?
Yeah, so I want everyone to take their sleep as key component of their health. You know, we always talk about exercise, good nutrition, focus on sleep health. Getting 7 to 8 hours of normal sleep is key. You know, like I said in the previous talk, maintaining the rhythm of sleep is very important. So anchoring the wake-up time, fixed wake-up time is what we call, you know, good light exposure, having morning exercise in the morning, staying awake throughout the day. And if you have to nap, short nap, less than 30 minutes. Nighttime, dimming light, you know, minimizing things that chocolate, caffeine, alcohol, smoking, these are all bad things that affect your sleep. So, and then, you know, getting the enough amount of sleep. But when there are symptoms, the threshold to be tested should be low. Sleep apnea is, and sleep health is one of the key factors that we think is affecting people's mind, developing, you know, deposition of substance that causes Alzheimer's disease. Sleep is a time where the brain gets washed out of its debris. So it's key component. And in fact, in my world, you know, sleep takes precedence than wakefulness because that's the one that cleans things. And the wakefulness is the one that burns all the energy. So get your sleep evaluated, take it as a key component of your health.
All right, and then we did get a last minute question. Are there any special pillows to use with sleep apnea?
So if there is diagnosis of sleep apnea, not the pillows, we want the side position. They're called positional devices for sleep apnea because the issue is not on our neck position. It's completely turning you to your side, often to your left side. So there are things that you could wear. And they're all, you know, you can get it on Amazon and other things. If you look into positional therapy for sleep apnea, that would help. Anything that would put you to the side. There are also other things, you know, Luna and other technologies. These are computer-driven things that you would wear that turns you to your side when they sense airway obstruction. They tend to be more expensive, but you can also make your own, you know, a t-shirt with a tennis ball. It's the old treatment. The Mayo Clinic could send you a t-shirt for $10 for positional apnea if you call the, you know, the sleep clinic. So you can do all sorts of things.
Why the left side? And then somebody asked, would lying on your left side help snoring without a CPAP?
Yes. So the worst for airway caliber is when we're on our back, supine position. The next is right side. Left side has more of the caliber. This was extrapolated first from observations of pregnant women. You know, if you assume with no, you know, intervention, mostly pregnant women would assume a left side position to help improve airflow. It's from there an MRI study was done to see what's the caliber in different positions. For the majority of the people, side position is best. From right, left position is good, and back is the worst.
And I guess if somebody does not have sleep apnea, would that help with snoring?
Yes, it helps the snoring. It does. What we call disruptive snoring. No airflow obstruction, but disruptive snoring to an extent it affects bed partners and family. That we suggest an appliance has to be done. The American Academy of Sleep Medicine standards an appliance has to be done. But insurance would not cover it, unfortunately, so it would be out of pocket cost. But for milder snoring, even the simple things like, freeze-dried strips, nasal sprays, side positions, putting alcohol close to bedtime, that's key. Alcohol reacts the airway muscle. Snoring gets worse if it's within 2 hours. So lifestyle changes are helpful.
Okay. And then here, my husband says I start snoring almost immediately. Is that an indicator of sleep apnea?
Yeah, so it tells me two things. Number one is you're quite sleep deprived, because when we sleep, if we're in a lighter stage of sleep, the snoring is not that loud. As we go into the deeper sleep, especially when we reach into the REM sleep, the dream stage is where we lose our muscle tone in the upper air passage. So snoring is much higher. So as soon as you hit the bed, if you slip in within less than 5 minutes and start snoring, it tells me there is chronic sleep deprivation. And of course, yes, that's the type of person that I would say, get the home monitor and see. The idea is to catch sleep apnea before it causes complications, before you develop high blood pressure, before it affects your metabolism, before it makes your morning blood sugar go up, before mood change, before depression starts, before accidents happen, before the brain memory loss happens. So those are things that we have to look at.
All right, thank you very much. That was wonderful. If you are listening to this and curious about learning more or have any concerns about your own personal situation, then I would encourage you to make a visit with Dr. Mekonnen. And we do have our in-house sleep lab as well as the home sleep studies. So whenever COVID is better, some of that stuff might, I guess, change with the in-house sleep studies. But talk to him. He can answer any of your questions. He's also a pulmonologist. So if you have asthma or COPD or any other kind of lung-related issues, he can help you with that. And also the intersection where all these things come together, he can help you. So thank you, Dr. Mekonnen.
Thank you.
And then on Monday, I'm going to be giving a talk on adverse childhood events and how they correlate with chronic medical conditions in adults. And then Wednesday, we have our 2 gastro doctors who are going to be here together. Dr. Wu and Dr. Tesfaye are going to talk about irritable bowel syndrome, diagnosis, treatments, and then also the uptick that they have been seeing in this stressful time. And then there will be no lecture on Friday. So if you guys have not gotten that email yet from Privia for next week, you should be getting it in the next couple of days. But thank you everyone for tuning in. As a reminder, all of the lectures and upcoming lectures are posted on our website. We have a YouTube channel, Rockville Internal Medicine Group. So if you missed some of the old ones and you want to see them recorded, you can always see them there. They do get posted on a little bit of a delay though, because we're busy people. And so sometimes posting things doesn't happen right away. But thank you to everyone. I hope you have a wonderful weekend. And thank you to Dr. Mekonnen for your time.
Thanks.
All right, take care, guys.